Assalamu alaikum. The clinical day started with Mr. Joe Smith, 68 years old man, referred to your clinic with headaches associated with a gradual deterioration in his vision in the right eye. His wife has noticed that he has become very forgetful. Please take a history and perform focus examination. Summarize the finding to the patient and explain investigation management plan. Ready?
Good morning. I am Dr. Musa, doctor in the Nerve Clinic today. Let me confirm you are. How can I call you, please? How you would like?
My name is Joe, doctor.
Okay, nice to meet you, Mr. Joe. You are wife of Mr. John. Yes.
No, I'm Joe. Yes. No.
Yeah, you are Joy.
Yes, I'm Joe.
Yes. Okay, Mr. Joy brought to my knowledge that you have a headache.
Yes.
Yeah, okay. Could you tell me more about this headache, please?
Yes, I have this headache. It started 2 months ago, and it's coming and going. So that's why my wife told me to come to see you.
Okay, Mr. Joy, sorry for that. I hope we are help you after this discussion. But let me know, this headache is worsen or just the same attack?
I think it's become more frequent and more worsened than before. Yes.
Okay. Sorry for that again, Mr. Joy. But it is the first time since 2 months or any previous headache?
No, usually I was having normal headache, general headache, and it wasn't frequent. But this headache is unusual for me and started 2 months ago.
Okay. Mr. Joy, did you notice anything that worsened your headache, like sneezing or coughing or leaning forward?
Yes, I think this also make my headache more worse.
Okay, sorry for that. What about coffee or tea?
What?
Coffee or tea. It is
Coughing?
yes.
Yes, also I noticed it's increased with coughing.
Okay. Did you notice anything that improve your headache, like any pills or any position or sleeping?
No, I'm thinking when I'm taking some paracetamol, sometimes it helps.
Okay. Okay, very good. Mr. John, can I know the site of the headache exactly?
I think I have it all over my head and also in my front of the head. It's more. So it's all over my head, but more in the front.
Okay. Can you describe to me your headache? It is dull aching or stabbing or throbbing?
It's dull aching.
Okay. Does this pain go to anywhere, to the neck or to the shoulder or
No.
anything?
No.
Okay, Mr. Joy, can you grade this pain? 1 is minimum and 10 is maximum. How much you give this pain to?
7.
7?
Yes.
Okay, sorry for that. Again, Mr. John, are you having any weakness?
No, I don't have any.
In your body? Any numbness all over the body?
No.
Any abnormal movement?
No.
Okay, very good. Are you have any fits or disturbed conscious level?
No.
Any problem in your vision or smell?
Yes, I think also my vision. I started to not to see with my right eye.
Okay.
I'm not quite sure. I think I should visit optometry to check it, the optician. And also, you said about the smell. Yes, I'm thinking that I started not to smell. I was having COVID 3 months ago, but I'm not quite sure. Is this change in my smell is related to the COVID? Because they are saying it could be related to COVID, or this is related to the headache that I'm having now.
Okay, sorry for that. Okay, what do you mean about vision problem? It is You can't see distance or any sight,
No,
coloring or greatness.
no, I think I was able to see, to read with a newspaper, and I able to read the sign in the street. But I think with my right eye, this has been affected.
Okay, is there is pain during movement your eye to
No.
the left?
No.
Okay, very good. Mr. John also brought to my notes that you have some sort of forget.
Yes.
And could you tell me more about this event?
Yes, I started to forget a lot of things at home. When I'm putting my mobile, I forget where it is. And also when I'm going out to do shopping, I have a list, but I forget to bring most of the things. And also I noticed that I started to have a lack of interest. And
Okay, so
I usually was happy to go walk with my dog, but now I started to sit at home.
okay, for that, Mr. John. But this forgetfulness only for recent event or old event?
No, I'm forgetting the things at home. If something I'm doing.
Recent. Okay.
Yes.
Okay.
I forget to put my thing where I put my things. Forget to sometimes I forget to I keep the oven open and I forget that the food is on the oven. So this is happening with me.
Okay. About the skilled movement. Did you lose your skills?
What do you mean?
Like writing or
No.
okay, very good. Mr. John, can I ask if you have fever? Any fever?
No.
Neck stiffness?
No.
Okay, if any weight change?
I'm not quite sure about weight, but I think that my clothes start to be loose.
Okay. Okay, what about your appetite, please?
I'm eating, but I'm not eating as before.
Okay. Do you have night sweating, especially at night? Especially at night?
No, I didn't notice that.
Okay. Did you have any skin changes?
No.
Like any rash or like that?
No.
Or like do you have any joint pain?
No joint pain.
Okay, any cough? Or
No.
cough of blood?
No coughing of blood.
Okay, any racing heart?
No.
Okay, Mr. John, sorry for that, but what about your water work? Any change in water work, like increasing frequency or loss of ability to control your water work?
No.
Okay, very good. Any change in loose stool or constipation?
No.
Okay, Mr. John, can I know what are you having long-standing disease? Should be aware.
Yes, I was having high blood pressure, and I'm taking amlodipine.
Okay. Okay. For how long do you have this blood pressure, increased blood pressure?
For 7 years now.
Okay. Any recent change?
No.
Change in doses of drugs?
No.
Okay.
My blood pressure is controlled.
Okay. Are you have any family history of early death or stroke?
No.
Okay, very good. What do you do for a living, Mr. Joe?
I'm retired.
Okay,
I make early retirement.
Okay, what was the previous job?
I was working as accountant.
Okay, very good. Mr. John, do you smoke?
I was previously smoking, but I stopped smoking, quit smoking 5 years ago.
Okay, how much and how long?
I was smoking about 1 pack per day for 10 years.
Okay. Okay, do you drink alcohol?
Socially.
Okay, very good. Did you any history of recent travel?
No.
Mr. John, can I ask if you have any history of blood transfusion or shooting a needle or tattoo?
No.
Okay. Mr. John, are you have any family history, any past history of blood clot?
No.
Stroke or mini stroke?
No.
Okay, very good. Are you have any, sorry for that, but are you married?
No, I'm not married. I'm living with my partner.
Okay. Did you have any other casual unprotected relationship?
No, I'm with my husband for a long time.
Okay. Okay, Mr. John, are you have any joint pain?
No,
Any back pain?
no back pain.
Okay, Mr. John, can I ask if you have any problem in your water work, especially at night?
No,
Uh,
no, I don't have this issue.
You don't have any dribbling of urine, of water work, or
No,
sense of breath evacuation?
no.
Okay. Mr. John, can I examine you?
Yes, please.
Okay, first I examine the general look for the patient for any wasting, then the hand for wasting, and then I examine the pulse.
Normal.
Okay, blood pressure.
Blood pressure 150/95.
Okay, then I will examine for proximal myopathy.
Nothing.
Nothing. Okay. Then I will examine the eye for visual acuity.
There is decreased visual acuity on the right eye.
Okay. Okay, then I will examine the heart for pulse and any murmur.
No murmur.
Sorry, I will up again to the neck for any carotid breathe.
No carotid breathe.
Okay, then I examine lower limb for any lower limb edema.
No lower limb edema.
Okay, then I will examine neurological for the power and reflex.
Power reflex are normal. On the upper limb, you mean?
Or lower limb normal.
Normal, yes.
Oh, okay. Mr. John, can I ask, do you drive?
Yes, I'm driving.
Okay, private car or?
Yes, I'm driving my car.
Okay, Mr. John, you should stop driving because you have a problem in your eye. Then will be assessed, and we will tell you how much exactly you should stop driving. It's okay with you?
Yes, okay.
Okay, Mr. John. Mr. John, do you, I know, can I know if you have any concern?
Yes, I'm concerned about what's happening with me. Is this cancer?
I appreciate your concern, Mr. John. Cancer, but cancer is it is also in our differential diagnosis. We have to exclude it. You have red flags or alarm signs of cancer, like old age and also loss of weight, loss of diet. So we should go through this investigation to know it is cancer or not, but it is likely to have cancer. Second thing, it is maybe due to your age, like dilatation in your brain vessels, brain blood channels, that increase due to increased secretion of the increased secretion or decreased excretion of the brain fluid. So also we have to exclude it.
2 minutes
So
left.
So what we are going to do, we will admit you, and we will do some investigation and some scans and advanced scans. Maybe need to take a snip, from your brain column, the main column. If you accept, you should sign a consent for that. So what and after result appeared, we will have another meeting to discuss the result. Do you have any other concern?
Okay. No.
Okay. Mr. John, can I ask you if you have any rigidity in your arms?
Rigidity in my arms?
Yes.
No.
Okay. Any weakness?
No, I don't have weakness.
Okay. Your blood pressure controlled? Yes.
Yes, my blood pressure is controlled.
Okay. Okay, Mr. John, do you have any other concern?
No.
Okay. Thank you. It is important to stop driving till we'll be assessed by eye doctor. If you have any problem, we will have another meeting to discuss the result. Okay.
Okay.
Okay. Thank you, Mr. John.
Still 10 seconds, Dr. Mahmoud. If you want to offer test to do or examination, would you do anything? What do you
Yes, I will do visual acuity. Yes, visual acuity and field.
You did the visual acuity. I told you the right eye is decreased visual acuity.
Mhm.
And
Yes,
then,
exactly.
okay.
What else other than the visual acuity? Okay, the time is up. Let's go to the examiner question. Because
Fundus examination.
exactly. Okay, let's start the examiner question. Please, Dr. Sarah.
Okay, can you present your case?
Okay, today I examined Mr. John, who has have headache 2 months ago with blurring of vision. This headache increase was coughing and sneezing and leaning forward. This gentleman also has some memory loss and forgetfulness. He also complained of loss of weight and loss of appetite. So my differential diagnosis and his neurological examination was normal. So my differential diagnosis will be in the top according to his age, and he has memory loss. In the top of my differential diagnosis will be normal pressure hydrocephalus. Against that, there is no urine out work urine controlled. My first diagnosis will be vascular disease due to patient old age and ex-smoker and hypertensive also. Maybe also stroke in posterior circulation. In the bottom of my patient diagnosis will be maybe cancer.
Okay. And what you will do for this patient?
Okay, first, this patient we will do CT for exclusion of any hemorrhage, and then we will do MRI for diagnosis of patient normal pressure hydrocephalus, and we will do also LB after taking consent. LB is LB will be diagnostic, and then we will do carotid duplex. Also, we will do ECG and echo. And for other complication, we'll do cholesterol level and LDL.
And what is the treatment patient?
What is
the management?
Management treatment? If our diagnosis confirmed if patient had normal pressure hydrocephalus, we will be by I think VB shunt, ventriculoperitoneal shunt, or ventriculovalvular shunt. Also, it will be patient education and counseling, and maybe need a card or bracelet if he had forgetfulness. And VB shunt. And good control of blood pressure and the treatment of any risk factors.
Okay, and if this patient you have time for do more examination, what you will do?
After CT, MRI, I will do fundus examination.
And do you expect to see anything in fundus examination?
Yes, I expect increase papilloedema due to increase intracranial pressure, and also we maybe have hypertensive. Due to hypertensive, maybe have wiring and maybe aneurysm or central artery vein hemorrhage like that.
Okay. So I don't have other question.
Other cause of normal pressure
I
hypercapillus?
finished my question, but I
Okay,
think I still time.
Okay, I will ask him that 1 minute remains.
Okay.
So you want to do LP, right?
Yes.
What's the indication of LP in this patient?
Indication he has a headache and he is now has intracranial hypertension.
Okay. What are the contraindications for lumbar puncture in this patient?
Contraindication.
What you should do before doing lumbar puncture?
Blood coagulation.
Okay, what else?
I don't know the best.
Will you do CT brain?
Yes,
Exactly.
CT brain.
Excellent. Okay. If you have signs of increased intracranial pressure, would you proceed for lumbar puncture? Still, you are planning for lumbar puncture? Like brain edema.
Yes, brain edema. Yes, Dr. Bas.
Will you proceed or you will stop?
I will stop.
Okay. I guess
I
fair
think.
enough. Okay. Thank you, Dr. Mahmoud. Let's hear Dr. Sarah comments, then I will comment.
Okay. So I think you cover some points, but for this patient, he's complaining of decreased visual acuity, forgetful, and headache. So when you examine, I think if you didn't miss an examination, you might get the diagnosis. It's not idiopathic intracranial hyper. It's not what is
Normal pressure
no,
hydrocephalus.
not normal pressure hydrocephalus. No. So when you're examining, when you ask first, you didn't ask about the vomiting and sickness, because this patient might have vomiting sickness. You can't ask also about double vision, because these are signs of increased intracranial hypertension. So you forget about to ask about the vomiting, nausea, double vision. And then on examination, when you examine the eye, you examine only the visual acuity, okay? So when you should examine the visual acuity, and then you do a full visual eye examination for the optic nerve. So because the patient has decreased visual acuity, so he might have optic atrophy. Okay, it's only in one eye. So you should continue your eye examination by examining the visual field. When you will examine your visual field, you will find the patient has loss of central vision and central scotoma in the left eye, and also when you offer the ophthalmoscopy, and also the pupillary reflex, he will have relative afferent pupillary reflex in the right eye, and in the left eye he will have a papilledema. So this patient has Foster-Kennedy syndrome. It's difficult case, okay. I say that it's difficult case, but when I read it, I think it's better to do it. So Foster-Kennedy syndrome, the patient will have optic atrophy on the side of the tumor, and papilledema on the other side. Okay, that's why you will find optic atrophy on the right eye, decreased visual acuity, and sometimes visual loss, and relative afferent pupillary reflex on the right eye. And then on the left side, you will find papilledema and central scotoma due to edema of the optic nerve. This patient told you he has anosmia because Foster-Kennedy syndrome, it means that the patient has a tumor on the right side or in the frontal lobe. Okay, this tumor compressing the optic nerve, and due to increased intracranial pressure, there is papilledema on the other side. Okay, so you heard about this condition before?
Really, first time, Dr. Sarah. First time. I just know stroke.
Yeah. It's a difficult case, but I think
Yes,
it's a good one. It's so the Foster Kennedy syndrome, they said, because the patient has a tumor. Okay, the tumor in the frontal lobe, maybe the tumor on the frontal lobe of the left side. Okay, so he will have the tumor, because in compressing on the left side, you will have optic atrophy on the left side, and on the other side you will have papilledema. Okay, and because also the tumor in the frontal lobe can compress the olfactory nerve, that's why the patient have anosmia. And because the frontal lobe is one of the centers that control the memory, so he might have lack of interest, as I told you, forgetful, he might have impaired inhibition. Okay, so this is the diagnosis. I think you don't need to say Foster Kennedy in the exam, but if you will get the diagnosis, you should do the examination. This patient complaining of visual disturbance. If you did the full eye examination, you will say the finding. So I found that there is optic atrophy on the right eye, relative F with pupillary reflex, and they might also say no need for ophthalmoscopy, but you might see the relative F and pupillary reflex. Okay, so you will get the diagnosis, and if you don't, you can say this patient, the top differential, this patient has a tumor, so you can say space occupying lesion. You need to do further investigation if you don't know this condition. Okay, so this patient has a tumor, and when they ask you about the differential diagnosis, differential diagnosis first is a space occupying lesion tumor. It could be also optic neuropathic ischemia, or ischemic optic atrophy, and it could be also neurosyphilis or infection. Okay, and the cause of this patient might have frontal lobe tumor. It could be meningioma, glioma, and also you should ask also the patient about any previous history of surgery or irradiation, because irradiation can cause the frontal lobe tumor. You should also ask about the hearing. And when you examine the eye, you might find that in the eye that he has papilledema, he might have double vision or diplopia, because this is sign of increased intracranial pressure. You should ask also about the balance, any change in your balance. The increased association with this tumor, it could be due to previous irradiation, previous surgery, neurofibromatoma type 2. This is the case, and the investigation, you did it well, CT scan, and then you continue with MRI. Sometimes you can give steroid to decrease the papilledema. This is, and you include multidisciplinary team, including the neurology, the physiotherapist, the neurosurgery. So this is the case. I know it's difficult. Okay, I finished my.
Yeah, thank you. Thank you, Dr. Sarah. Very nice case, as usual. And new case, we did not practice it before. It's a space occupying lesion. Fair enough to say it. No need to say Foster Kennedy, or just the space occupying lesion is much enough to get your mark. But I will ask Dr. Mahmoud, you have constitutional symptoms, which was positive, and the patient concern was about cancer. Then you said it's in the list, in the bottom of my list, and you didn't give any importance to this symptoms. I mean, loss of weight. And why you suspect something else? Still, you have high suspicious of cancer.
Yes.
Keep it in, and the patient concern was about it. So better to keep it in the top, and you can put whatever you want after that. Okay, you reach mostly to the diagnosis. When you said, I thought you catch the case when you said yes, one of the possibility, because you have weight loss and so on. Then you change your diagnosis while explaining to the patient, no, you don't have, or the cancer in the list, but it's low or low probability. I guess with loss of weight, loss of appetite in any patient, we have all of us to think about cancer. And if the patient concern was about cancer, we can respect that and we put it in the top. Let's go back to the history, what you missed in the history. Cancer history specifically, since you have loss of weight, loss of appetite, you can ask specifically any family history of cancer. And if you suspect cancer in the brain, you can ask any cancer of the brain in your family. It's okay to ask this question, by the way, and it might be there. Okay. I don't know if Dr. Sarah can give us any clue about it, any positive family history for cancer, brain cancer, I mean.
It's written that it could be related to neurofibromatosis, previous irradiation, but it's not
Yeah,
something, you know.
it wasn't. Okay. But
Mm.
some cancers running in family with some genes inheritance, so we can put it as concern in the family history. You have any family history of cancer? Most of cancer running in family, or some of cancer running in family as a familial condition or genetic condition. So we can ask it particularly when you suspect it. Okay, not every patient you will ask, but if you suspect, you can ask. Especially cancer colon, some types of polyposis in the colon, it might be related. And men, of course, men as a cancer, one of the top of the inherited cancers genes. Let's go back to the CNS analysis by Dr. Mahmoud. You should ask about behavior change, as Dr. Sarah said. Most probably this patient will lose his control, and behavior will be either aggressive or he will be misbehaving, not as before. If you can ask him, especially when you have something affected apart from his vision and the headache, you have memory loss, so you can suspect. Do more analysis and deep questions in the analysis of the CNS system. So the mood change, the behavior change, the sleep, the stress, as we are saying before, SMS means the sleep, the stress, and memory. Sleep, memory, stress, or sleep, stress, memory, whatever. But in such patient, you have to ask about the behavior. Does he lose the behavior or control of his temper or whatever? He will be aggressive in his behavior, or he'll be changing in his behavior. One of them, the memory loss. Okay. The weakness and the sensation, you ask and you ask again, but you didn't test it. Yes, one of the possibility. So you have to ask again, does you have any change in the sensation? And if no, you can do it. If no, do the pronator drift test. Do some neurological examination which can give you a clue, or you can get a mark from it. What you will examine in this patient? Only CNS. Patient came with 2 or 3 CNS manifestation. So you have to examine full neurological examination. And the vision affected in this patient, you offer only acuity, and you find the acuity is lost. Okay, you will not do the field because the acuity is lost. But why you didn't offer the fundoscopy? This was my question. What you
But
want
the
to add?
acuity is not lost in the other eye. You can share.
Yeah, you can do the other eye examination. But if you said yes, no acuity in this eye, okay, I will not proceed for the field. Yes, as Dr. Sal said, you can do the field in the other eye. Leave the field now if you want to skip the field. Do the pupils, the reflexes. You know the examination of the eye, 4 letters, afro. A for acuity, F for fields, R for reflexes, and O for ophthalmoscope. You skip the 3 tests, which were, or one of them will be the clue of this patient. The ophthalmoscope and this patient will be target and diagnostic test. You will have optic atrophy in one eye, and the other eye will be having papilledema, which is Foster Kennedy syndrome. Okay, it's not common, but once you have frontal lobe lesion,
But you might have it.
yes, of course, any patient with frontal lobe specifically, they might have the Foster Kennedy syndrome. The lesion will compress the unilateral or the ipsilateral optic nerve, so you will have optic atrophy in the ipsilateral side, and because of the compression signs, the CSF will be edematous, or you will have swelling in the brain in the other eye, so you will have papilledema. This is the Foster Kennedy syndrome as definition. And the test for LP in this patient, I guess, will be contraindicated. because of the signs of increased intracranial pressure. So at least offer it. Don't put it in the first step unless you have done CT brain to rule out or to measure the intracranial pressure or to rule out any brain edema signs or any signs of increased intracranial pressure. Again, it's maybe you get the diagnosis from CNS complex manifestation, but the walking difficulty will be the clue for normal pressure hydrocephalus. It's a triad of walking difficulty and increased intracranial pressure signs and urine retention. I mean, cognitive dysfunction and urine retention and walking difficulty. These
Urine
are the
incontinence.
sorry.
Urine incontinence.
Urine incontinence, yes, walking difficulty and cognitive dysfunction.
Retention.
Sorry, sorry, yeah, it's not retention, the opposite. He will lose the control, so he will be in incontinence. Yes, urinary incontinence, walking difficulty, and cognitive dysfunction. You don't have all of these. Even the cognitive dysfunction here is not cognitive dysfunction. He is not in dementia. This patient only forgetting, or he has forgetfulness. So I guess the diagnosis here will be wrong, and better to keep your answer as cancer and continue putting it in the top of your differential. Roll it out first. Don't say I could think. No, it's the top of your differential. And the good thing you catch the constitutional symptoms. Apart from this, I can't add any comment on the examination or the history or the social history.
I
The
think
driving,
yes, we can add this is mini mental status is in
one of the scores, yes, can be
yes,
used.
and also we can ask him about orientation to place, time, and person because the forgetful. I
Exactly. You
important.
can, yeah, you can add also examination of lymph node in the cervical, auricular, and the area of the brain. Just offer, or you can act like you are examining the lymph nodes. Why you are? Because you are suspecting cancer. So still one of the possibility you might have lymphadenopathy. It's not necessary one, but you have to do it. Okay. Apart from this, I don't have more comment. But when you have time and you finish the concern, still you want to do something which you suspect about cancer. I mean, you can do any neurological examination, particularly the ophthalmoscope. By the way, they are not bringing fundoscopy anymore, or maybe they will bring it again. But I mean, offer it. You will not be harmed if you offer the fundoscopy. You can ask, and they will say skip or whatever. But you have to offer fundoscopy in such patient and any patient having visual affection or any vision affection. Okay, the good thing here also for the welfare, you ask him about driving and you advise him immediately. Then at the end, you advise him again, don't drive. Okay, I think you give him advice about smoking, and this is enough for the smoking because he's considered as heavy smoker.
No,
One
but
packet per day. Yeah.
ex I said ex-smoker, so he asked on
Ex-smoker. Okay, good. Okay. I guess we covered the topic well. Thank you, Dr. for the case.
Can
Any
I
question?
add one comment?
Sure, yes.
So I think the onset of the headache and the visual problems is a clue. Here, the onset is gradual onset, not sudden onset.
Yes.
So sudden onset, I will consider vascular thing like vasculitis, stroke, hemorrhage, sudden onset of headache. But here, gradual over 3 months, I think. So matching more space occupying region rather than stroke, because stroke, it would be more acute. So the onset is clue here as well.
Yes, you're right. You're right, Dr. Ahmed. The onset and the progression of the vision, it will be for a long time because the slow rate of the cancer will make the vision affection gradually. Let's put the differential in this patient. So once we have patient with headache and vision affection, I guess we can put in this patients particularly, we will put cancer in the top, space occupying lesion, whatever the kind of the cancer. Then you can suspect glaucoma. So you can ask the question of glaucoma because you have vision, but it will be against the glaucoma, the long duration. So, but still, it's one of the differential of vision affection along with the headache. And you can put also multiple sclerosis as vision affection plus CNS manifestation. These are the common scenarios and the common differential. You can add GCA, giant cell arthritis, because also you have vision affection along with the headache. But I guess it will be also acute presentation. It will not be for the long term. So the second matching differential in this patient will be multiple sclerosis because it will be in the long term and chronic course. But the glaucoma and the GCA will be much acute. Stroke also you can put it, but again, it's acute onset. Anyway, any symptoms or any differential with both affection, you can add it. I don't know if Dr. Sarah asked you about the differential, but I can say these are the differential for this patient. And Dr. Sarah, if you want to add any differential or you put in from your scenario, you can add it.
No, you did more differentials that I said. This is good. Only tumor, as you said, ischemia. But I didn't say the giant cell arthritis. You are right. So this is right.
Okay, thank you, Dr. Sarah, for the case again, and Dr. Mahmoud for the practice. Let's go to the second scenario. Any question from others?
I know this is a difficult scenario, so I don't want you to be.
No.
Don't
Really,
worry.
This is
Very
no.
good.
difficult. You know, it for me. This is the first time that I see it today, but I found it in one book. I see it's more good interested in the exam. They might not bring and we couldn't maybe see. They should dilate the eye to check for the optic nerve and all these things. But I think it's as a differential as a space occupying lesion and to do the examination of the eye, the full examination. But it's difficult, I know.
No, Dr. Sarah, again, I prefer to say better to face such scenarios in our practice rather than in the exam. In the exam, you will be in stress and too much hard words from the doctor, the comments.
Because they started to bring all the difficult cases. There is one also like
Yeah, so by the way, if you practice the case once only, you can do it perfect in the exam.
yes, they brought one case I think, but I don't know what exactly in the case. It's patient with headache has a brain surgery for glioma and a neurofibromatoma, and he's coming as a long case with headache. So it could be I don't know what exactly happened in the scenario, but it could be a tumor
Recurrence.
recurrence. Yes, that's
Yeah. Recurrence or radiation, for example, radiation and headache or something related to the post-cancer removal. So consider the primary lesion complication, either the surgery or the radiation or the underlying pathology, the primary pathology, which is the cancer. It might be recur again.
Yes.
So you can do a differential around these things. Don't think about something away. Don't say it might be migraine. So it doesn't make sense to think about something it's very far away from your differential. I guess something related to the cancer itself or the surgery or the procedure or the recurrence of the cancer itself.
Yes.
Okay. Sometimes also medication can be side effect because you have some past medical history of significant. You have to think about it. Don't skip this and think about something out of the box as they are saying. So first think about the box. You have cancer, you have surgery, you have medication, you have chemotherapy, you have radiotherapy. Maybe one of these could be the reason. So I guess this is it will be the case or maybe something related to. Okay, let's go to the second scenario. Thank you, Dr. Sarah, for this case. I like this case, by the way. And Dr. Mahmoud is lucky to practice this case. Can you write the case scenario, Dr.
No,
Mahmoud? Sorry?
he wrote it for me.
Okay. Mrs. Sarah, so why you are putting her name in front? Okay, 28 years, recurrent fits, please address.
Sorry, it is mistake, really. It is mistake, really.
Problem. Okay, just
Call Miss Sarah, no problem. You can say
no. I prefer to change the name while you are.
Okay,
discussing.
Mrs.
You
Sarah.
can edit. You can edit.
Yes,
And
yes, okay.
you put Mr. also. Okay, put it Mrs.
Okay.
I hope this is easy scenario. You won't get your revenge.
No. It's too easy.
Hopefully. You know, I'm not good in anything. I'm good in the difficult one.
That's why I give you this case. It's too easy.
Okay, hopefully.
Miss Salwa, 28 years, recurrent fits. Please address my concern.
Okay, I can start. I was preparing while you was discussing the case.
Okay, Dr. Sarah, my advice to you, don't think about I prefer to be simple or difficult. Any case you have to practice it and don't prefer thing on others.
Yeah.
Okay?
Okay.
Yeah. So do it, please. You
Okay.
can do it. Yeah, here you go.
Hello.
Hello?
My name is Dr. Mahmoud, one of the doctor here in the clinic. Am I
Okay.
talking to Mrs. Salwa?
Yes, doctor.
And are you 28 years old, right?
Yes, all right.
I'm here to discuss about your health condition. I might ask you some question, and then I will examine you. And at the end, I will try to answer your question and address your concern. Is that okay with you?
Sure, doctor.
Okay. So I can see from your notes that you are complaining of recurrent fit. Is that right?
Yes,
And
doctor.
tell me more about that.
Yes, doctor. Since 2 days, I have lost my conscious for 5 minutes. And my husband told me that I lost my conscious and shaking my body. So it was just 5 minutes. So I come today to know why this fits. I afraid a lot from having any cancer like that.
Yes, I really appreciate your concern.
Okay.
It's stressing for you, but I want to assure you that you'll get the bottom of this. But let me first ask you some question. You told you have this loss of conscious only once?
No, doctor. I think since 1 month also, I have the same, but just for 2 minutes.
2 minutes. And what do you mean
Yes.
loss of conscious? You black out?
Yes, I didn't know what happened, but also my husband was with me and told me that my body shaking.
Okay.
Mhm.
When you had when you have the both before having this loss of consciousness, what you was doing exactly?
I was sitting,
Sitting?
not
You,
anything, no particular thing, no.
no, you wasn't doing any sneezes exercise or
No, doctor, no.
and in both it's only 2 times, right?
Yes, doctor, 2 times.
Both
Then,
times there is no
it is yes, the same. I think it's the same.
and you didn't notice there's something specific would trigger this loss of conscious, right?
I don't no, doctor, no.
And before you loss of consciousness, did you notice that you feel sick?
No, doctor.
Did you feel sweaty?
No.
Okay. Did you notice any flash of lights?
No, doctor.
Any numbness in your face?
No.
And you told me that your husband witnessed you when you have this loss of consciousness. So
Yes.
you said your body was shaking. All
Yes.
your body?
Yes, all my body.
And have you noticed also any uprolling in your eyes?
No, doctor.
And
I don't think.
I'm sorry for that. By any chance, did you wet yourself?
The second time I wet myself.
You wet yourself. Okay. And have you noticed also that your tongue is sore after having this loss of consciousness? You bit your tongue?
No, doctor. I don't notice. No.
Okay. And did you hit your head in both time?
Yes, I feel my head was heavy, but no injury in my head.
But you mean I'm saying that you hit your head on the floor or something?
I didn't remember, doctor. I was falling. I didn't remember anything.
Okay. And husband didn't say to you anything regarding that you hit your head, right?
Okay.
Okay. And after having this on both time, did you remember anything?
No, doctor.
And did you feel yourself dizzy after having this loss of consciousness?
No. I recovered fully conscious.
Fully conscious. Okay. And okay, and just to ask you other questions, yes or no, if you don't mind.
Okay.
Do you have any fever,
No, no.
recent infection, flu symptoms or infection?
Flu symptoms? No, no, doctor.
Okay. Did you have any headache?
No, no,
No headache. Any
no,
your vision?
no, no problem about my vision.
Any change in your speech?
No, no, doctor.
And any no change in your foot. And in both time before having this, you said you didn't have any trauma to your head, right?
No, no, doctor.
Have you noticed any weakness in any part in your body?
Yes, doctor. Sometimes I have weakness in my body. Sometimes.
What do you mean by that? Can you tell me more about it?
It is some weakness in my right hand and right leg.
Okay,
But some weakness, but it is recovered the second day.
on the second day. So it's
Yes,
stayed for 1 day,
yes, yes, doctor.
and this weakness is increase more at night.
No, no, doctor. It comes only 2 times. Since also 1 month.
So you have also you think that it could be it started at the same time that you have this loss of consciousness, correct?
I think so. Yes.
Okay, and can I ask you also, have you noticed any change in your bowel habits?
Just a bit, just constipation. Yes.
You have constipation for 2 months,
Yes, doctor. For 2 months.
and do you feel that you started to be more thirsty?
More seriously, no, no,
You go to the loo more frequently?
no, no.
Okay, and you told me you didn't have any sweating or feeling sweaty or shaky after have sweating before having this loss of conscious, right?
Yes, doctor. No, no problem about that.
Have you noticed any tingling or numbness in your hand or in your face?
No, no, doctor.
Okay. And no vomiting, right?
Just vomit 2 times through this month. Last time was 2 days ago.
So you have vomiting also.
Yes, yes, doctor.
This was related to the loss of conscience that you're having or at different time?
No, I think it is a different time.
Okay. So you have
Yes.
constipation. Okay. And okay. And can I ask you, do you have any medical condition?
Like what, doctor?
Any any medical condition I should be aware?
No, no, no.
And when you had this loss of conscious last month, you didn't seek any medical advice for that?
It's just 5 minutes. So second time I go to my GP. He gave me some medication and tell me, and it's just a painkiller.
Okay.
And told me that because my mood might be.
Okay. And okay. And are you taking only paracetamol? Any other what painkiller he gave you, the GP?
He gave me ibuprofen.
Ibuprofen, yes.
Yes, and also I have some tummy pain. Take also ibuprofen.
So I'm taking ibuprofen for tummy pain. So you have also tummy pain.
Yes, I have tummy pain. Yes,
Since
sometimes I have tummy pain.
okay, and this is related to anything?
I think I go to my GP. And I am pregnant now. I am the second month of pregnancy. So he told me maybe due to my pregnancy.
Okay, so you are pregnant in second month and he give you ibuprofen.
Yes, yes, doctor, I'm pregnant.
Okay, and you are taking any other medication apart from the ibuprofen?
No, it is the first pregnancy. I married since 3 months, so it is the first pregnancy. So I am worried. My mood is very bad. Maybe because I am, it is the first pregnancy, so I am worried about everything.
Yes, I really appreciate your worry. You know,
Okay.
And you told me this is the first pregnancy. Any previous miscarriage?
No, no, doctor.
No.
No.
So I just want to ask you also, do you drive?
Yes, doctor.
So and what do you do for a living?
I'm housewife.
Housewife, okay. So I just highly advise you to hold your driving because you have this fit. And we'll discuss it with you, and we might inform the DVLA because when you have this fit, you might have it while driving, and this causes risk for you and your baby, and also to the people. How does that sound?
Okay, doctor, no problem. Okay, fine.
So, and do you smoke?
No, no, doctor, no.
And you drink alcohol while doing?
Just occasional. Just
Okay.
occasional, yes. In the
Okay.
weekend.
Okay. Any previous surgery?
No, no, doctor.
Okay. And you said that you are married 2 months ago, right?
3 months ago, yes.
Months ago. And before that, you was taking any contraceptive, any
No.
birth control?
Why take contraceptive? This is the first marriage.
Okay.
Mhm.
So I would like to examine, is that okay with you?
Sure, doctor. Sure.
Okay. First of all, I need to check the vitals.
Okay. What do you need?
The vital signs, blood pressure.
Vital signs, pulse 90, 90,
Mm.
and blood pressure 120/80,
Mm.
and respiratory rate normal 20.
Okay. And then I would like to check the hand first. I would like to have a quick look.
Okay, normal.
Okay, power and tone,
Normal.
reflex,
No, reflex normal.
phonated drift.
Normal.
Okay, and then and coordination.
Normal.
Okay, and then I would like to examine the cranial nerve. I would like to do ophthalmoscopy.
Yes, normal, doctor.
Check the visual field.
Normal.
Okay, and then I would like to examine the heart for any murmur.
Normal.
The neck for carotid breathe.
Normal.
And also I would like to examine the chest for any crepitation.
Normal.
I would like to examine also the lower limbs, neurological power tone.
Normal.
Okay, and power tone reflex are normal.
Normal. Yes, power normal. Yes.
And coordination.
Normal.
Okay, so what is your main concern, Mrs. Salah?
My concern, doctor, what I have.
Okay.
My GP told me that maybe due to pregnancy, why my mood is low, why this fits. I afraid I have any cancer in my brain or like that.
I really appreciate your concern, but because there is a lot of things that run in my mind, so I would like to admit you to run for you some tests to check your electrolyte, the salt in your blood, check your blood sugar, and also we'll do for you a heart racing, and also I would like to do some imaging on your some tracing on your brain to check, because it might be that it could be first it could be a type of migraine.
2 minutes left.
Which is type of headache that can cause fit and can cause this weakness in your arm. And also it could be you had this fit, it could be a newly diagnosed epilepsy. Have you heard about this condition?
Yes, doctor, but what is the cause of tummy pain?
It could be
Is it related to my pregnancy or other thing?
it could be related to some electrolyte, some salt disturbance in your body. So that's why I need to run for you some tests. And I'll come to you to discuss with you the management plan.
Okay, but about the scans, it is safe in my pregnancy?
We will try to check to do the test first, and then we'll ask I will ask consultant because if you can do tracing on your brain, it's normal. But some of the scan, we have alternative scans that we can do it for you.
Okay, doctor, thank you. But am I need admission in
Yes.
hospital?
Need to admit you to get to know exactly what's happening with and to keep you under observation because you might have this fit again. And her blood pressure was normal, right?
Yes, normal. Yes.
Okay. I need.
What about constipation, doctor?
We'll give you medication for that. Okay.
Okay, doctor. Thank you very much.
Okay. Okay. I finished.
Any advice?
Yes, I will keep her under observation, and I advise her to stop driving. She will.
Perfect. Okay. Yes, let's go to time is up. Let's go to the examiner questions.
Okay, doctor. Present your case, please, and give me the pressure diagnosis.
Okay, I examined this 28 years lady who's presented with a current fit. She has also loss of consciousness while having this fit, which was also witnessed by her husband, that he said that she has shaky movement and wetting herself. She has also abdominal pain and constipation. She's pregnant in 2 months. So when on examination, I didn't appreciate any positive finding. So this patient might have a newly diagnosed epilepsy, and she might have also migraine.
Okay, doctor. What about okay, go on, doctor. Sorry.
Hypoglycemia. It could be electrolyte disturbance. So this is my defense.
Okay, but why she had weakness?
It could
She
be
had episode of weakness.
Yes. Could have transit ischemic attack.
Okay, doctor. Weakness plus abdominal pain plus constipation. Okay, what about her mood?
Hypocalcemia. Hypercalcemia. Yes. I said electrolyte disturbance. I didn't ask her about her mood. Yes, she told me her mood is bad. Yes. Hypercalcemia could be. I said electrolyte disturbance and also hypoglycemia. This is my defense.
Okay, doctor. Okay. What's your investigation?
So for this lady, because she's pregnant and she has this attack of fits, we need to keep her under observation.
Okay.
I will do for her the routine test, checking her blood sugar, full blood count, renal function, liver function, and EEG. This is the investigation that I will do it for her.
Okay.
This is all that I need.
Okay, doctor.
With the multidisciplinary team, I will include the gynecology team and the internal medicine. And according to the investigation, we'll start for her the treatment.
Okay, doctor. Thank you very much. Okay.
Still 2 minutes, Dr. Mahmoud. If you finish question, I can ask here some. If you have some other question, you can ask here.
No, I finished. Doctor.
Okay, so I will ask here, you investigated your patient, right?
I think so. I didn't get the diagnosis even. Okay.
Okay, let's think about the differential. So what are your differential?
My differential could be electrolyte disturbance, hypercalcemia, hypoglycemia, newly diagnosed epilepsy, and she might have eclampsia, but her blood pressure was normal.
Okay, perfect. Yeah, you can think it, but eclampsia will be at the last trimester. This is the first trimester.
In the first trimester, yes.
So you can say hypertension, encephalopathy. Okay. Did you ask about the use of any drugs?
No, I
Might
said
might be the reason.
yes, you are right. Recreational drugs, yes.
Yeah. So it might be. Okay, if you suspect migraine in this patient, so what will be with and what's against?
For migraine, I think the loss of conscious won't be with the migraine. She might have abdominal pain due to migraine. She might have hemiplegic migraine by the weakness explained.
Perfect. Yes.
We're
So
up conscious.
it's one of these. Okay, what about pregnancy? Is something related to the pregnancy you can think about?
For the weakness,
Yes.
because she might have transient ischemic attack, antiphus clot.
Okay.
Mm.
What about headache with pregnancy?
Hypertension.
Hypertension or another hypertension, I mean in the brain. But it will be associated with headache.
I don't know.
IIH, I mean. It could be, I'm not sure also, but it could be the reason. But it will not be associated with epilepsy. So in the top of your differential epilepsy, whatever the reason, because this patient had generalized tonic-clonic, right? You asked about the movement and he said, let's hear from Dr. Mahmoud. I think time is up. Dr. Mahmoud, you can comment, then I will comment.
Okay, patient admitted with recurrent epilepsy. She is pregnant since 3 months, and the fits start after 1 month of pregnancy, associated with tummy pain, constipation, epilepsy, low mood. So the case will be acute intermittent porphyria triggered by pregnancy.
Wow. Okay.
Patient alcoholic.
Doesn't only you mean the mood? This is neurological symptoms.
Yes, these neurological symptoms comes with epilepsy.
Low mood.
Yes, low mood, psychomotor symptoms, triad of weakness. Sometimes I told you sometimes weakness, and during examination, I told you power is normal.
Mm.
So power have sometimes weakness and constipation and tummy pain and epilepsy and triggered by pregnancy. You know, my desire to hidden from you the pregnancy, but okay.
I was thinking I will.
You will ask me what about your period? I will tell you regular. I will not tell you that I am pregnant.
Is young age, but you said before I will ask. But it
Yes.
didn't give me the clue even. It's make it more difficult.
No, why is difficult? I told you constipation,
Also,
tummy pain.
Asian, I know I will do for her CT brain. I couldn't do all this imaging on why she's pregnant.
Yes, Dr. Sarah. So it is acute intermittent porphyria.
So she has recurrent epilepsy.
Yes, second time epilepsy and the tummy pain start after pregnancy. So the pregnancy is the trigger of acute intermittent porphyria.
And this is a difficult case.
Oh, why difficult, Dr. Sarah?
Okay. Okay.
But I don't know, am I clear or not clear about the history?
Actually, it was
No, it
difficult
is
for us
clear.
as well.
Psychiatric issue plus abdominal tummy pain.
Yes, if you collect it clear, yes.
Sinus pain, that's sinus problem I miss. But the issue here, pregnancy. Need
Yes,
to
the trigger.
collect anything
The trigger here
related
is
to pregnancy.
Mm-hmm.
Yes, but pregnancy makes the scenario difficult.
Pregnancy
If normal
plus
person can catch it.
yes. Pregnancy plus alcoholic. The two triggers for, but pregnancy is who is the one is the trigger factor of this condition. You know, oral contraceptives pills and pregnancy can trigger porphyria.
Can trigger porphyria, okay.
Yes, the two. Plus alcohol, stress, infection.
Okay.
Yeah, thank you, Dr. Mahmoud. Very nice case.
Thank you, Dr.
Yes, yeah, difficult one, but maybe Dr. Sarah didn't analyze the abdominal pain more.
Yes, if she told me what
Yes.
tummy pain, I will tell her it is a severe pain. I take
Colicky and
yes, colicky and
I guess Duksara, you skipped the abdominal pain or the tummy pain. He gave it to you this.
When he said, I said all of this, I become confused. So I said I don't want to ask about the abdominal.
No. You have to ask about every simple and every single positive finding in the history.
Want to open more the
No. Don't correlate abdominal pain to the pregnancy. I guess you
No,
thought like that.
No, I didn't correlate it, but I found it's become more difficult for me and a lot of complaint, and I didn't. So I said that I don't want to ask about it. Keep it like this.
No. Any positive finding in the history, analyze it. Whatever the situation, even delayed or you are late at the end of the case, or even after the consent, if you suspect something in the history which you didn't analyze it, do it. Abdominal pain in this scenario will be a clue. That's why also all of us lost, because we don't know what is this abdominal pain. If you analyze it, you can find the clue. The urine also, I guess you didn't ask about the waterwork change.
So to diagnose acute intermittent porphyria by annular symptoms as epilepsy or low mood, abdominal pain, and the third thing is what? Constipation or the urine?
Urine change, long standing, will be dark.
But Dr. Bassem, it would be long standing. So the patient didn't notice.
Yes, sometimes they will deny it, but particularly if you ask it, at least to show the examiner that you are asking about something in your mind. And if she denied it, you will get the mark because you know what you are asking about. Okay. I guess these were the finding in this scenario. So let's repeat the clues.
Yes. The person talk about the acute intermittent porphyria, the whole topic, okay, while you are discussing.
Yes, it's an important topic, and the triad of not triad, a lot of findings. So from the CNS, as you saw in the case, weakness or neurological manifestation, mostly motor, okay, motor neuropathy or motor affection, weakness or whatever. Then psychiatric illness, again, still in the brain, CNS, weakness and psychiatric affection or illness, depression and thoughts, ideas of depression. Then recurrent abdominal pain on and off, and the water or the urine change on standing, it will be dark. These are the character of acute intermittent porphyria. The frequency of the attacks of abdominal pain or motor neuropathy and the low mood. These are the components.
Meant by urine color change on standing. When we keep it for a long time, it will be.
Yes, if left for a long time, it will be this because of the urobilphenogen.
Yes.
Okay. The triggers also will be the clue for any porphyria cutanea tarda and acute intermittent porphyria. The same triggers, which are the alcohol, anesthetic illness, anesthetic medication, and this patient pregnancy. And also, I guess we mentioned the alcohol. Yes, hepatitis C and porphyria cutanea tarda, and other medication, painkillers. Yes, I remember also painkillers. These are the triggers, but the difference between porphyria cutanea tarda and acute intermittent porphyria, the skin change. In porphyria cutanea tarda, there is skin rash on its sun-exposed area. But in this patient, she will be presented with abdominal pain and psychotic illness, weakness, and the triggers as we saw in this scenario. Okay. And the treatment, I guess, in both hydration, you can do the hydration. Hematine in this patient, hematine will have role, but in the porphyria cutanea tarda, hydroxychloroquine, and avoid the triggers. OCP, yes, OCP, one of the trigger in both scenario, OCP and pregnancy. Okay, the hormonal, I mean. Yes, family history will be autosomal dominant.
Acute
You're-
intermittent.
Yeah, both of them, there is autosomal dominance in both patients. Okay. It's difficult, Dr. Sarah, but the lesson here, any positive finding in the history, you have to analyze it. Abdominal pain, don't skip it.
And for the porphyria cutanea tarda also, it's coming in attack episodes.
Yes, it comes in episodes.
Okay.
Episodic, either skin lesion or a change in the face. Okay. These are the presentation of both scenarios, and both of them linked together. There is, I remember in the past, in the step 2, there is scheduled comparison between 3 of these conditions. But the common in PACE is these 2, the porphyria cutanea tarda and acute intermittent porphyria. I guess acute intermittent porphyria more frequently than porphyria cutanea tarda, because it's abdominal pain. That one might be presented with skin rash or hair growth over the face. We did this case, I think, 2 weeks back. You remember, with Dr. Azhar, porphyria cutanea tarda. It was excessive facial growth. Porphyria cutanea tarda. Anyway, you learn the lesson again. As I said, any positive complaint, analyze it, even if you will skip other system, because it might be your clue. In this patient, the abdominal pain will guide you to the acute intermittent porphyria. The weakness also, I guess you didn't analyze it more, how it happened, which side, floppy or stiffy. Okay, you have to ask all these questions. The headache as well, you can ask about headache. I don't know if you ask about headache or no. But it's clear this patient having CNS manifestation linked to the abdominal pain along with the trigger. So it will be acute intermittent porphyria. And this attack comes with some triggers. If you ask about alcohol, yes, it will be related to the alcohol as well. And you have
Yes.
to advise.
Yes, Dr. Bassem. This case, Dr. Bassem, came the last year in Egypt with my friend. But instead of epilepsy, patient has low mood, and the clue also was tummy pain. But you know, Dr. Bassem, it is a real patient. I see this patient, epilepsy, recurrent fits, and has a lot of investigation and a lot of treatment, and the clue here was the abdominal pain.
Yes.
It is a real patient in ICU.
Yes.
Mm.
Okay, you can add to the differential epilepsy. Yes, of course,
sure.
epilepsy, yeah, on the top, because this patient presents with seizure, and this seizure a presentation of epilepsy. I mean, generalized tonic-clonic and loss of control. I mean, wetting herself and biting the tongue. You can ask all these questions. And the patient lost her awareness during the attack. It regains it after. It regained her conscious level after 5 minutes. He said that. But you have to ask about, did you check blood sugar, or anyone checked your blood sugar during the attack? You might have hypoglycemia, but the clue will be sweating and abdominal pain. But here again, you can put a hypoglycemia. Patient will present with seizure, abdominal pain, and shakiness or abnormal movement. So still similar to our condition. So most important question here also to check, anyone checked your blood sugar? Does your husband check your blood sugar? You got it? So these are the 3 differentiate our patients: acute intermittent porphyria, epilepsy, and hypoglycemic attack. You ask about constitutional symptoms, loss of weight, loss of appetite?
No.
So again, try to do as much as possible, quick system review and constitutional symptoms. Don't miss any of these. Once you will miss, they will comment on you. Okay? Loss of weight, sometimes it will guide you to the case. And you will be lost if you didn't ask at the previous patient. If you didn't ask about loss of weight, loss of appetite, you will miss the diagnosis of space occupying lesion. In this patient as well, it's important to ask, but if in this patient it will be spared, so it will be negative, no loss of weight. Instead, you will have gain weight because of the pregnancy. Okay.
Thank you.
Any other question? Any comment from others? Anyone can add, please. Yes, good case, Dr. Ryan. Really, Dr. Ahmed,
Yes,
Dr. Mahmoud.
I have something can add it,
Yeah,
but
sure.
from Google, عمو Google.
Mhm.
What direct treatment for this convulsion or epilepsy or this attack of fits؟
Control the underlying disease.
بس أنا هخلي الفيت شغالة وأقول control underline.
No.
ما
You
هي
have to control.
during أنا
So
خدتني.
for the epilepsy itself, ABCD approach. ABCD approach. Patient will lose his consciousness. He might be in apnea. He will not be breathing well. So as any patient with epilepsy in acute attack, ABCD approach. And as Dr. Sarah said, I will admit you. You have to admit this patient. She had 2 previous attacks and it will be warning for her. She has pregnancy as well. It might be harmed by the seizure. Right?
Okay, admitted the patient to the hospital.
Yeah.
Which
And
medicine can give it
medicine, you can say
for
safely,
convulsions?
I will refer or I will involve multidisciplinary team, including neurologist. Which is safe for her? I guess lamotrigine. But don't say this medication unless you have opinion from neurology because she's pregnant. So the lamotrigine is the safest medication
Yes.
in pregnancy as anti-epileptic. Apart
Ignore
from
it is pregnant. You get my point?
no
I want to ask
pregnancy,
a question. Which safe in acute
yeah,
intermittent
lamotrigine.
porphyria convulsions if the patient develop attack بتاعت seizure حدوشن.
In the acute, different than the chronic. In the acute, you can give benzodiazepine.
acute أيوه
Diazepam.
convulsion.
Yes, diazepam. This is the best.
benzodiazepine
Yeah, benzodiazepine in the form of
طيب not
diazepam.
available nurse
Other
asked search for
benzodiazepine.
you not available.
Other
Huh?
benzodiazepine. Other benzodiazepine like midazolam.
Can I add?
If
Can I
both
add thing?
if both not available, what can give the patient?
I
Okay.
think
Mhm.
is contraindicated or what?
Yes, it can trigger attacks in acute intermittent porphyria. No.
يلا
propofol.
دكتور باسم الديازيبام can induce crisis and it is contraindicated in the patient with porphyria. ليه
Okay.
قلت لك كده؟ لأنه خدت لك لستة طويلة عريضة.
Okay.
فأنا فرحت
So you are
إنه
asking
الديازيبام
about
إنه
the
ما
acute
موجود.
intermittent, not about the pregnancy. Okay. This is,
هي
yeah,
لا
it
acute
will be
intermittent
challenging.
acute intermittent. أيوة
Yeah,
يلا
it's
acute
challenging now.
intermittent قال لك the drugs a number of the drugs and chemical capable to regulating hepatic acute intermittent porphyria and are thus best avoided by the person which with acute intermittent porphyria such drug include الانتي medication هو الدراجز اللي بتديها لها هنا هي الكونترانديكيتد avoided حتى لك بالأحمر باربيتوريت فينوباربيتول هيدرانتيان لايك الفينيتوين ما عارفة اسم الجروب هيدرانتيان زي الفينيتوين اسفينيتوين كاربامازيبين سلفوناميد sulfamoxazole and also حرسي لكم في الجروب هي الاثنين فيهم سلفا واحدة نهايتها سلفاموكسازول واحدة سيما سوكزازول من غير ام يعني الفرق بيناتهم بس حرف الام. ايوه سلفا هنا موكسازول هنا سوكزازول.
What about
الحاجة
diazepam?
الثانية
Okay.
يلا قال لكي برضو قال لك الحاجات الافويدد من ضمنها الدايزيبام والجنرال انستيزيا عندها greatest risk to the people who have acute intermittent porphyria or has been recently. يعني الحاجات كلها خطرة لاحظتوا؟ طيب قدر ما فتشت ليش لقيته خطر. ده كله قال لك عنده greatest risk. الدايزيبام also قال لك بأنواعه. الدايزيبام can induce crisis كمان. It's contraindicated in patients suffering from porphyria.
No anti-epileptic porphyria.
Okay.
treatment.
So the best answer here will be neurology team. If you are
معناها
not, yeah, if you are
تصرفوا
not sure,
براها.
yeah, better not to
مع انه
start.
قال لك ممكن نديله الكونفشن، لكن بيعمل لك هنا اجريفيت الاتاك. طيب انا هعمل شنو؟ طيب induce crisis، وفي نفس
Okay,
الوقت قال لك ممكن نديله الكونفشن. معناته انا شنو اديله واخلي
but
الكرايسيس تيجي، بس نعمل شنو؟
yeah,
نوقف الكونفشن اهم شيء.
so the
تمام.
best way is to refer patient to neurology team, and this is what we are practicing, Dr. Samah. No, we are not prescribing anti-epileptic medication, especially those patients. I mean, childbearing period females, and with some disease we are not aware about or we are not familiar, like acute intermittent porphyria. So anesthetic and benzodiazepine, as you said, it's contraindicated and might trigger the attacks. However, in up-to-date, I checked just now, in up-to-date, lorazepam and midazolam are safe in acute intermittent porphyria. I will share the page in the WhatsApp group. So the diazepam, yes, you're right, it's one of the trigger, but midazolam, lorazepam are safe. Okay.
اوكي تمام.
Apart
Okay,
from
good.
this, you can say be sure that if you say this answer, you will be safe. I will refer the patient to multidisciplinary team approach, including the neurologist and also gynae and obstetric and the rheumatology. No, I don't think the rheumatology here. Hematology, yes, hematology, and so specialized nurse and social worker and so on. Clinical pharmacist as well. You can do like this group. But if he insists for some medication to say, you can say benzodiazepine. I will share again the page. Benzodiazepine in the form of midazolam and lorazepam. That's it. Okay.
اوكي ممتاز.
But
يعني
good
ما
to know.
كل
And
البنزودايزيبين.
yes,
ما
not
كل
all,
البنزودايزيبين.
but
تمام.
good point to
Okay.
raise it. Really, thank you, Dr. Samah, because the benzodiazepine or some medication are trigger for in this patient. Anesthetics particularly are also one of the triggers. And the other anti-epileptic are not safe in the pregnancy. The most safe one, lamotrigine. Apart from this, yeah. So if they ask you in the epilepsy, but I guess in this scenario, the epilepsy related to the acute intermittent porphyria, once you control it, the epilepsy will disappear. Yeah. Or the seizure, I mean. Okay, yes, you're right. It's not epilepsy. It's a seizure related to the acute intermittent porphyria. But a nice case. It opened a discussion, and Dr. Mahmoud also told us it's one of the real patient. You might have it as either neurological condition or as abdominal pain. You have to know such scenarios. It's familiar to the basis cases. Okay. Any other comment? I hear someone want to add comment. I guess it was about also benzodiazepine.
Me.
Yeah,
Ahmed.
please. Yeah, go ahead, Dr. Ahmed.
So the issue is status epilepticus is a medical emergency.
Yes.
So there is no A to E approach and there is no point for MDT. So I cannot wait for MDT to take decision to terminate the seizures. So I have to give something to terminate the seizure immediately. So I think the answer will be A to E approach and give whatever. I'm not, because my thought is benzodiazepine is can trigger acute intermittent porphyria as a group, but I'm not sure if you add on midazolam and
Yes, you are
lorazepam.
right صراحة. You are right. أنا في النهاية abort الأتاك if aggravated crisis, no problem. Stop the convulsion because of emergency.
The issue is if you give propofol to terminate the seizures will be more frequent, and if you give benzodiazepine, it will be the same. I'm not sure how to treat it if status epilepticus because it's challenging. I don't think it will appear in cases because it's too difficult for the consultant to manage. So it's not expected for medical SHO to treat it. So I think you are not marked against how to treat status epilepticus in acute intermittent porphyria. This is not our. I don't think so. I don't think this case.
I think it's out of scope of cases. Yes, you're right. Maybe acute medicine or something advanced like neurology or subspecialty.
Because
but Dr. Ahmed, this case I presented, the FITS was 2 days ago, not in status.
But medical SHO who is running MRCB UK basis
his level is very below this kind of things. So he will not be able to manage status epilepticus in very complicated scenario like acute intermittent porphyria. You are intensive care registrar, so your level is very higher than the candidate for MRCP by default. So the MRCP designed for SHOs, medical SHO, who is interested to become a medical registrar. So I think this is too difficult for them to catch. And how to treat status epilepticus in acute intermittent porphyria, it's very complicated and it's beyond, I think only consultant neurologist can treat it.
Yes.
So I'm not sure if can come to basis. I'm not, it's fine. It's good to learn. It's good to practice. It's good to know. But anyway, it's too complicated in case of emergency.
So what the take-home message in this patient is ABCD again. Yeah, secure the airway. Call the neurologist. I don't think any hospital don't include the neurologists. They have, and they are 24/7, either by call, even by call. You can call or you can do consultation by phone. What is the safest medication in this condition? You can just secure the airway and try to manage the circulation and the ABCD until the opinion get from the neurologist. Okay. So I guess the best answer here, ABCD approach in the acute attacks and refer to multidisciplinary team, including the neurologist and the hematologist and the gastroenterologist. The medication itself, it will be very challenging one due to the acute intermittent porphyria condition situation and the pregnancy situation. I guess this is out of basis scope, yes. But if we learn from this case today, I think we'll never forget it again. I will share the page again. But the best or the safest medication written was lorazepam and midazolam. I will share it again, or I will share it after the.
They won't ask us about the treatment because this is complicated for us.
Yeah.
Oh, and there won't be times. They want only the differential, the general measurement, the advice for the patient. I think this is too much to know the medication because we couldn't
Yes,
decide
exactly.
this medication as a SHO, and I think he's saying right, Dr. Ahmed, regarding the MRCP, but the MRCP it's not to see if you are suited for SHO. They want you to know if you will be suitable to be a registrar and taking decision. So the safest way to say that to include my consultant because we are not taking decision on our own.
Exactly, yes.
Only to be a safe doctor.
Yes, exactly. This is also important to mention that I will call my consultant or my senior to get opinion and the answer we mentioned already. But in the long term, the management of acute intermittent porphyria, the best measure for it is the preventive measure, prophylactic. If you avoid the triggers, the attacks will be less, even might be absent. Okay. And in between, this is the prevention. And during the attacks, hydration and glucose, IV fluid, and hematine as pharmacological therapy. The seizure we discussed already. And I guess the safest medication, as I said, lorazepam, midazolam, according to the up-to-date, and I will share it after the meeting. Anyone has other opinion? Please, let's hear.
Dr. Bassem, yes, as you said,
Go ahead.
Ryan.
Yes,
Yeah.
yes. Go ahead, Dr. Ryan.
So I just read from up to date, yes, as you said, that lorazepam is safe because it's short acting.
Yes.
Others, long acting, they are risky, so they said that better to avoid them. And another thing is the Keppra, levetiracetam.
Levetiracetam, yeah. Levetiracetam.
Safe. This is safe as well. So يعني لو if we are
Yeah. In
if we're
case of.
asked about this, yeah, and the patient came with fits, we can say that like lorazepam and Keppra.
Perfect. So this is double opinion now and reassuring one. Thank you, Dr. Ryan, for double check.
Thank you.
Thank you. Anyone has other comment? So repeating the advice for the pharmacological therapy for the seizure in acute intermittent porphyria will be short-acting benzodiazepine, lorazepam, and midazolam. By the way, diazepam, one of the long-acting. That's why they are giving as intermuscular. Okay. Apart from this, Keppra or levetiracetam, also safe medication, according or as per up to date. This is the take-home message, plus the ABCD approach, as we mentioned earlier. Any patient coming with acute attacks, do the ABCD approach without thinking. Be as a habit for you. If you have some condition which is presented as acute, tell the examiner if the patient in the acute attack or in the chronic attack. In the acute attack, I will do ABCD approach. They will be happy for this and satisfied. By the way, you will get good mark in the management plan. They need from you to hear this, because you will be safe, doctor. Why you are doing that? Because the life of the patient much important than the control of the disease in the long term. Okay, for the long term, the best and the first answer ever is multidisciplinary team approach, because you are not neurologist, you are not hematologist, you are not gastroenterologist. So the best thing is to refer this patient to multidisciplinary team approach. And this is the best answer in any chronic or any long-term disease. Okay. Any other comment, any other opinion, any other concern? Don't forget always the non-pharmacological therapy. It's also important, sometimes much important than the pharmacological. Not all disease will be controlled with medication. No, some of them will be controlled by preventive measures or prophylactic, or avoid the trigger, particularly. Like in this scenario, avoid the trigger. In asthma patients, sometimes avoiding the trigger will control the asthma itself. Migraine, cluster headache, sometimes also tension headache, irritable bowel syndrome. Any trigger you can prevent, it's much better than giving medication to the patient. Why? Because the medication having side effects, while the prevention will not have any side effects. Just you will get the benefit from the trigger avoiding. But for the medication, yes, you can control, but you might have some side effects from the medication. So the best way is to start by non-pharmacological lifestyle medication. The diet, the stress, the exercise, the smoking, the alcohol, all these control. If you control them, I can say this is controllable condition or factor. If you control them, you might control most of the disease risk. And you will be safe if you mention it. No one can say you are wrong for that. Okay? Anyone want to add any comment? Nice discussion today and nice showcase by Dr. Mahmoud and Dr. Sarah. Please feel free to comment either by writing or verbal. Great. Looks satisfied, all of you. Isn't?
Yes, Dr. Bassem, thank you very much.
Thank you.
Thank you.
Yes, tomorrow we'll have also off day. Sorry, some social issue also tomorrow and Friday as usual. So we'll meet again on Friday. Okay.
Okay.
Thank
Dr.
you
Bassem.
all for sharing with me the session. And special thank Dr. Mahmoud, Dr. Sarah, and all of commenting doctors, all candidates attending with me. We'll see you tomorrow, inshallah. Sorry, we'll see you after the weekend. Have a nice weekend. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ahmed, as well. Thank you.